Okay, I accept. Good evening and good morning to all of you, wherever you are in this moment. Welcome to our Knowledge Spot webinar on bone sarcomas. I'm Ornella Gonzato. I'm a long-standing and currently an appointed SPAEN board member. 15 years in advocacy since my sister Paola passed away because of an osteosarcoma. I'm the founder and president of the Italian leading patient advocate organization that deals with all types of sarcomas except for GIST. It's a great honor and a privilege to moderate this session today. Bone sarcomas are rare cancers, 8 to 10-fold less common than soft tissue sarcomas. They pose several specific challenges to patients and all those involved in their care. Osteosarcoma and Ewing sarcoma mainly affect children and young adults, even if osteosarcoma shows a second peak of incidence in the 7th and 8th decades of life. Conventional chondrosarcoma is the most frequent bone sarcoma of adulthood. Chordomas are even rare cancers with a median age of diagnosis of 16 years, even if skull-based presentations can affect a younger population, including children and adolescents. Given their rarity and the complexity of patient management, the accepted standard for bone sarcomas is treatment at the reference centers within dedicated networks, able to provide access to the full spectrum of care and age-specific expertise. At these centers and networks, treatment is usually given within either the framework of prospective, often collaborative clinical studies or established treatment protocols. A multidisciplinary approach by sarcoma experts within a multidisciplinary team is mandatory in order to identify the most appropriate treatment strategy for each patient. So it's my pleasure to introduce our speakers who will share with us their different perspectives, starting with Dr. Nathalie Gaspar, who will provide the medical oncologist point of view, focusing in particular on multi-kinase inhibitors as promising treatments for osteosarcoma and Ewing sarcoma. Then I'd like to welcome Professor Campanacci, Director of the Department of Orthopedic Oncology and Reconstructive Surgery at Correggi Hospital in Florence, and full Professor of Orthopedics at University of Florence in Italy. Our last guest is Professor Beate Timmermann. She's an expert in radiotherapy and radio-oncology with many years of experience in the field of proton therapy. Professor Timmermann is the director at the Practice Therapy Clinic and head of medicine at the West German Proton Therapy Center at Essen University Hospital. I'm very grateful to our speakers for having accepted our invitation and being with us. I would kindly recommend them to do their best to stay within the range of 20 minutes. Questions from the audience will be answered at the end of all presentations. You can raise your hand for direct questions or send them through the chat. Please, Dr. Gaspar, the floor is yours.
Thank you very much. I'm very pleased to be here. You need to let me share my screen because at the moment I'm not allowed to.
It should be working now.
Can you see the screen?
Yes.
Okay, perfect. Then I'm very pleased to be here and very pleased to present the medical oncologist perspective on bone sarcoma when I'm a pediatric oncologist. I think it's already a very good start. I'm part of different working groups, consortium that are very important in bone sarcoma. The newest one is the Foster Osteosarcoma Consortium. I'm also part of the Euroiming Executive Committee and the Hibiscus project that I will talk to you about all that are all bone dedicated, but also to an initiative that is called Fair Trial Group from Accelerate, that is more dedicated to AYA with cancer, but in these cancer that are really specific from AYA population, even if you can see it through age. I think it's very important to discuss with you what is done in this group and how you as patients and parents advocate can participate to that. I will not talk about all sarcomas, but just two of the primary bone sarcoma, which are osteosarcoma and Ewing sarcoma, with a peak incidence in adolescents and young adults. They are both bone sarcomas, but very different in terms of presentation, in terms of histology, in terms of predisposing syndromes that exist for osteosarcoma, and it's more ethnic predominance in Ewing sarcoma, and in terms of tumor genetic, which is very different. Osteosarcoma has a very chaotic genomic, and Ewing sarcoma is supposed to be to have a simple genetic with a transcript of fusion, usually from EWS FLI1. But you will see that it's not so easy than it is thought. And the main problem of these two disease are the metastatic capacity and the resistance to chemotherapy. I will focus the first part of my talk on multi-kinase inhibitor in bone sarcoma, because that's the something that I've raised as being important in the last year. Kinase family are proteins that represent a huge amount of the proteins. It's around 500 different proteins with and represent 2% of the genome. They are multiple, and tumor cells can be dependent on this kinase, on different kinase between osteosarcoma and Ewing sarcoma, but some are similar. And you can have also a very different dependency between patients with a huge patient heterogeneity, especially in osteosarcoma. These kinase are also present in the tumor microenvironment and on the vessels, but not only, but also in all the immune cells that are present in the tumor microenvironment. And that's very important because if you try to target one of the kinase, which has been done in, for example, Ewing sarcoma, in Ewing sarcoma, it has been initially a huge hope and finally turned to despair. At the contrary of other diseases like some lymphomas, where when you target just one kinase, you're able to control the disease. In bone sarcoma, this is not the case. And even if you can observe very absolutely strong regression of the tumor with this with that kind of treatment that target on just one kinase, this is transient, and the mechanism of resistance are not very known. And then this is possibly due and probably due to the plasticity, not just of the tumor, but also of the tumor microenvironment. Then in the last year, what has been developed is more multi-kinase inhibitors that have an anti-angiogenic activity, but also an activity on the cells. But they are targeting very different kinases. Some are similar, some are different. Which one is the most important is difficult to say. But what we have observed in the clinical trial is that there is some efficacy in bone sarcoma, both in osteosarcoma and Ewing sarcoma, when they are used as single agents. There have been multiple trials with these drugs, this kind of drugs, and it's clearly a class effect as single agents. And in these drugs have been tested mainly in relapse setting. You have here the example at the osteosarcoma relapse setting with efficacy against placebo. But these trials are mainly adult trials with very different disease presentation, with very heavily pretreated patients, with miserable disease and not evaluable disease. And at the end, there is very few objective response, even if you can maintain the disease long. And we don't know anything about long-term effects, especially in the population, in the pediatric population. Some effect has also been seen in relapse osteosarcoma, Ewing sarcoma, sorry, with different drugs as single agent either. But now there are some questions that are remaining and trying to be answered at the moment. And this year was published one paper about combination in osteosarcoma, because one of the questions is, can we use that inhibitors with chemotherapy? Because the toxicity that they present might interfere with chemotherapy. Then there was one trial which was called the HOPE trial in relapsed osteosarcoma, where we tested lenvatinib, which is a multikinase inhibitor, with chemotherapy. What we observed is that tolerance was acceptable. The main side effect that were observed was due to the chemotherapy, as usual, with nothing more, and some toxicity specific to multikinase inhibitor, like hypertension, and some of the patients have experienced pneumothorax, which is quite specific of osteosarcoma treated with multikinase inhibitor. In addition, the efficacy was important. However, this trial was a single-arm trial with no comparison arm. Then we don't know if the efficacy that we see is just the chemotherapy efficacy or the chemotherapy efficacy plus the lenvatinib efficacy. We have then set up a trial that is called the HOLY trial, a randomized trial this time, that we are comparing the chemotherapy alone versus chemotherapy alone plus lenvatinib. This trial has just closed in 2001, and then we expect to have the data, the results in 2002, end of this year, to be able to tell you if the efficacy that is seen is increased by the lenvatinib, which is the multikinase inhibitor. We are now also introducing this multikinase inhibitor in the Ewing sarcoma relapse setting. And this is a new arm that is discussed in the trial that is called RECURE, which a trial that is in relapse osteosarcoma. And I've compared different chemotherapy to try to define what is the standard chemotherapy. And now that the standard chemotherapy is defined, there is new arm that there are new arms that are added, including arm with or without lenvatinib. There are other combinations that have been tried, where there are some osteosarcoma and some Ewing sarcoma that have been included, but not specific. But they all show that these drugs were tolerable with the chemotherapy, which is important for the next step, as the next step will be to try to understand how to introduce these drugs in first-line treatment. You might know that the treatment in both osteosarcoma and Ewing sarcoma are composed of different phases. First, you do the biopsy, then you do a neoadjuvant chemotherapy, then you do the local treatment with surgery plus radiotherapy for Ewing sarcoma when it's needed, not for osteosarcoma, as usually it's a radio-resistant bone tumor. And then you have adjuvant chemotherapy. Introducing new drug, especially multikinase inhibitor, within this treatment can be a challenge. There is different steps where you can introduce them. The challenge could be the tolerance with the chemotherapy, the efficacy, of course, the stratification of the patient. Do you introduce this drug to all of them or just to those that have the poorest prognostic? The duration of the treatment is also something that we don't know yet. And is there an optimal multikinase inhibitor with the maximum efficacy and the lowest side effects? That's something that we don't know, as well as the optimal schedule. Then there are currently different trials that are open. The easiest way to introduce this multikinase inhibitor is to introduce them after the end of the treatment as a maintenance treatment. And there is 2 trials ongoing. One for patients that are in complete remission at the end of the treatment, which is called REGOSTA, and one at the end of the chemotherapy treatment for patients that are still with disease, and that's the REGOMAIN trial. And this trial tests the regorafenib during 6 months versus placebo. That's interesting because in terms of tolerance, there is no interaction with the chemotherapy, but we don't know yet if this setting is the optimal setting, as we are in the state that we call minimal residual disease, not with a huge bulk disease. The tolerance of this treatment that prolong a treatment that is already quite long will be something that we will need to evaluate short after the during and after the treatment, but also for long-term effects. The Chinese have tried to introduce the multi-kinase inhibitor after the surgery, which is interesting. But for that, they are decreasing the chemotherapy that they are giving to the patient, and I'm not sure that is the optimal setting to do that. Then maybe that's something that will have to be followed and see if it's interesting or not. And in Ewing sarcoma, both previous examples were in both sarcomas, but for Ewing sarcomas, we are trying to introduce them from the beginning of the chemotherapy in a very specific population, which are the multimetastatic Ewing sarcoma, where we know that the prognostic is not better than a relapse Ewing sarcoma. Then we are trying to introduce it first in a phase 1b to test the tolerance of the multi-kinase inhibitor with the chemotherapy used in Ewing sarcoma, which is VDCIE. And then if it's efficient, we have already the phase 3 that we are setting up probably before the end of the year to try to introduce that strategy in a randomized way for all the metastatic patients. But even if we have knowledge of efficacy as single agent, hope that there is efficacy in combination with chemotherapy, how this multi-kinase inhibitor really works, what are the kinases that are important, that's something that we still don't know. Then ITCC, which is the Innovative Therapeutic for Children with Cancer consortium, has set up in last November during their scientific day, a day dedicated completely to multi-kinase inhibitor in sarcomas to try to see what are the data, biological data that we need to take advantage of all the samples of patients that have been collected during this trial to try to understand what are the kinases that are important in osteosarcoma and Ewing sarcoma and which combination we should use, because maybe the combination with chemotherapy is not the only one that we can choose, and maybe there are combinations with other kinase inhibitor or other targeted therapies that can be used. These questions are so important than the Accelerate platform has set up also a strategy forum. And I don't know if you're familiar with Accelerate. Accelerate is a multi-stakeholder platform with pediatric oncologists, pharma regulators from the EMA and the FDA, and patients and parents advocates to try to speed up the development of drug in pediatric cancer. And they have strategic forum to try to define a strategy in some disease. And this year, the strategy forum was fully dedicated to multi-kinase inhibitors in bone sarcoma. I cannot tell you more because it was confidential, but you will be able to have the paper probably before the next year, the end of the year. There are other drugs that are interesting, targeting just below the transcript in Ewing sarcoma, which is the TK216, but toxicity with chemotherapy might be too high. We will know, we will see how the results, the final results of the study are to be able to know if it's interesting. Similarly, there are PARP inhibitors that have been developed, which target the DNA repair. But again, with chemotherapy, toxicity is increased, then maybe the development will not be able to be further. There are some trials that are trying to combine multi-kinase inhibitor with immune therapies, especially in bone sarcoma. And as you can see, all that requires collaboration, and the role of patients and parent advocates in this collaboration are very important. The Eurohearing Consortium is a consortium that is existing and dedicated to Eurohearing and try to bring together all multi-stakeholders in Europe. But for years, there was no osteosarcoma consortium, and we have just set up in 2021 the Foster Consortium for Fight Osteosarcoma through European Research to try to have an overview of osteosarcoma and to have all multi-stakeholders working together. And we also have an hibiscus program that is a transatlantic program. The hibiscus program is mainly to put all together a database with all the clinical data of the past trial and be able to ask questions to know better this disease. The Foster Consortium is a consortium that includes already 20 countries and with different work packages that goes from biology up to data sharing. Then they will go through the setup of clinical trials, but also to discussion about quality of life, local treatment, imaging, and at the end, the objective is to improve the outcome of the patient. The biology is something that is very important, and we need to take advantage of the disease-specific research, the trial biology ancillary study, and also several programs that are developed in Europe and elsewhere about tumor molecular profiling to orientate the discussion. And again, data sharing, being able to share all the clinical data and all the biological data is important to better know everything. The Accelerate group is also trying to improve one problem that we have in bone sarcoma. Even if we are very keen to try to share and to be, and we are able to have a joint protocol in phase 3, in phase 2, we still have protocols that start at 18 years and stop at 18 years, which is a problem in this disease that is across age. Then there is the Fostering Age Inclusive Research Group, the FAIR group, that is acting to avoid this 18-year dogma barrier in early clinical trial, with a paper that have been published already a few years ago, but a clinical website where you can find help to try to do that, help for oncologists, with all the multi-stakeholder support from pediatric and medical oncologists, from the health authority, from the pharma, which has produced a letter saying that they're keen to try to introduce adolescents in adult trial. And you have also patients and parents advocates with testimony in these trials. We have also developed toolkits for the investigator and the sponsor, a stamp to reward the trials that are including adolescents in adult trial. And there have been a toolkit developed also for patients and parent advocates for the FAIR group. And bone sarcoma, there are new drugs coming. We need to learn how to use them in the first line setting, especially. There is need to know more about biology to inform better the future drug development, and multi-stakeholder collaboration is essential, and participation of patients or parents are crucial. It has helped, for example, during the Accelerate Forum meeting, to make the pharma understand that it will be important for them to share the samples that they have collected in their trial to be able to know better why multi-kinase inhibitors are working and in which population. Thank you very much. And if you want to learn more, the SIOP meeting this year, which is the pediatric oncology, as a day where 3 sessions on bone sarcoma, one on Ewing, one on osteosarcoma, and one about the collaboration with ITCC. Thank you.
Thank you very much, Dr. Gaspar, for highlighting the pediatric oncologist perspective. In any curative strategy for bone sarcomas, surgical resection of the primary tumor is regarded as essential. Surgery may also play an important role at different stages of the disease. Surgery should be carried out only by highly experienced surgeons, first and foremost, orthopedic musculoskeletal surgeons. Recent new technologies and new materials are allowing an even more complex and personalized surgery from more accurate prediction models, increased precision, and better functional outcomes. Surgical planning and surgical navigation, 3D printing, artificial intelligence, and reconstruction implants are reshaping the orthopedic oncology landscape, providing benefits both for patients and surgeons. So it's my pleasure to invite Professor Campanacci, who will share with us his experience and perspective as an orthopedic surgeon. Please, Dr. Campanacci, please, the floor is yours.
Thank you very much, Ornella. It's a real pleasure to be here with you tonight. Good evening to everybody. And if we have to talk about what's new in bone tumor surgery, we must say that we are going towards personalized surgery. And first of all, we need intraoperative guides to guide ourselves during the operation. And then we are able now to use custom-made devices and implants and customize some allografts. And also we can correct patient-specific deformity at the end of skeletal growth with the aid of new devices. So we know that orthopedic oncology is a compromise between maintaining the safety margin required for tumor resection and excessive removal of functional tissue. So a high surgical accuracy is crucial for patient survival and optimal functional outcome. And this is the reason why we need intraoperative guides for a better precision. So we can use cutting guides, which are patient-specific, navigation systems, or probably in the future, we can go towards augmented reality. We begin with cutting guides. They are 3D printed, so patient-specific, and they allow us to perform joint sparing resection and multiplanar resection, and to use customized allografts, bone allografts, and also customized prosthesis. This is an example of a multiplanar resection of a paraosteal osteosarcoma using a custom-made cutting guides. You see, if you have a Ewing sarcoma, an osteosarcoma, excuse me, of a 9-year-old boy of the distal femur, which is going to the growth plate, but is not passing the growth plate. What you want to do in a case like this is to preserve the epiphysis of the child. So this is what we used to do a few years ago, using this Kirschner wire to guide our osteotomy, to preserve the epiphysis together with the ligaments insertion of the cruciate and collateral ligaments. This is very important for the functional recovery of the patient. And for reconstruction, we used an allograft together with a vascularized fibula. This combination allows mechanical resistance together with biological activity of the allograft. And you can see the result at 10 years of follow-up, very, very good. But if you operate a growing child, of course, you will have a limb length discrepancy at the end of the growth. So this patient had 5 centimeters of discrepancy, but now we have these devices which are revolutionary because they allow lengthening of the bone with non-invasive technique. You see, this is a electromagnetic field which is able to elongate, to lengthen the nail and to lengthen the bone. So we corrected the deformity and the limb length discrepancy of this child completely. Very, very good result in this case. Another application of cutting guides, custom-made cutting guides, are joint sparing resection. You see this patient had an adamantinoma, which is a malignant tumor in osteofibrous dysplasia, and it was necessary to perform a joint sparing resection to preserve, you see, the epiphysis of the tibia. And a 3D model of the tumor was performed, and custom-made cutting guides were produced for this specific case. So very precise osteotomy was performed, and a different cutting guide was prepared for the allograft, because the allograft needs a different cutting guides made on the anatomy of the allograft. And this is so the intercalary resection that we perform using an allograft and the vascularized fibula of the same leg, in this case of the patient. You see the result at 6 months and the complete fusion of the grafts at 12 months. So we have said joint sparing resection, but also multiplanar resection. This is a paraosteal, a peripheric chondrosarcoma of the proximal tibia, which was of the periphery of bone. So the epiphysis in this case could be preserved. So we made this project for a multiplanar resection to preserve as much as possible the healthy tissue. So this is the objective now. And this is the cutting guide, the custom-made cutting guide that we use for the resection, and a different cutting guide studied on the anatomy of the allograft for the modeling of the allograft to replace the defects. This is the result. After 1 year, you can see that the allograft has completely remodeled, and you don't see anymore the osteotomy line. So one way to go for intraoperative guides are cutting guides, but another way is to use navigation systems. Navigation systems which are particularly useful where the anatomy, the three-dimensional anatomy is complex. So in the pelvis, in the spine, in the sacrum. What are the advantages of this technique? To achieve better margins, more adequate, so better local control of the tumor, to be more precise on the osteotomy, to have a higher safety on neurovascular structure, better allograft matching, and also a more accurate reconstruction regarding the length, the height of the joint line, and the rotational alignment. So these should lead us in the future to have less complication. But the indication to use this technology are, as I said, the place where the three-dimensional anatomy is challenging and is difficult, and especially cases like this, osteosarcoma of the sacroiliac joint, very difficult resection because the anatomy, three-dimensional anatomy is complex. So in this case, navigation can definitely help. And this was demonstrated by these authors that went to see in pelvic and sacral bone sarcoma, comparing patient treated with surgical navigation and patient treated without surgical navigation. And they said that with surgical navigation, our margins on the bone are much better, 81% with respect to 50%. But the margins on soft tissues do not improve because the navigation does not work on soft tissues, because soft tissues moves and they have no fixed referee point. So navigation can help us to be more conservative, like in this case, chondrosarcoma of the scapula. We want to resect just one part of the scapula to preserve the rotator cuff and especially the glenoid in order to maintain the function of the patient. And this is what we have removed in the X-ray of the patient. And navigation can be used also for joint sparing resection, as we have seen before with the cutting guides. This is a particular case made from our colleague from Hong Kong, very, very interesting. They preserve just a little piece of epiphysis of this child, and they used this intercalary joint sparing prosthesis to reconstruct the distal femur. You see how thin was the epiphysis remain, but this was very successful because this patient from age 6, you see the growing of this epiphysis with time, the growing in length, but also in width. So the growth through the Ranvier ring of cartilage remained. And the prosthesis is very stable. So navigation can help. Now there are new technologies. There are intraoperative CT scan. They are very expensive, not available in every operatory room, but this probably is the best to have the more accurate precision. And for the future, we hope that augmented reality will help us. These are some studies on animal models. There is a overlay of images using some special glasses or special mask, like the HoloLens. We can see the imaging of the patient overlaid on the anatomy of the patient. This was a case which was done clinically, and you see what you can see. The red one is the tumor, and the green one are the margins that we want to achieve resecting the tumor. This is one of the last paper that was published about this issue, and also always on animal models, and the authors concluded that the technology is helpful, but the current results do not yet justify a clinical trial without further in vivo animal studies. So we can use intraoperative guides, but we can use also custom-made implants made for the specific patient. But what are the indications to use these devices? The sites where no modular implants are available, so the uncommon sites, like, for example, the calcaneum. There are no modular prostheses for the calcaneum, so custom-made prostheses can be used in this clinical situation. But we need to see what will be the future and long-term follow-up results of this reconstruction. Another site is the talus. This is another case of custom-made prosthesis replacement of the talus. Another indication are extensive bone loss of the pelvic or scapular girdle, because also in these sites there are no modular implants available. So if we want to replace a scapula with a prosthesis, we have to use a custom-made prosthesis. And in particular, there are cases where only the bone is involved, and you can spare all the periscapular muscles with their innervation. So this is very important for the function. And you can project prostheses that go to replace only that particular specific part of the scapula with excellent functional result, always using, you see, the cutting guides. But when the tumor goes out from the bone, you need to remove the entire scapula. And in this case, you can use a custom-made prosthesis of the scapula with a constrained mechanism. The constrained mechanism provides better stability and better functional result in this very difficult and very challenging operation. The same thing on the pelvis. There are cases where you have to remove a part of the pelvis and you need to replace the pelvis. And one of the possibilities is to use a custom-made prosthesis. This is the differentiated chondrosarcoma of the pelvis, very aggressive tumors invading the joint space. So what we had to do was an extra articular resection, removing the entire joint. And this is the preoperative model planning that we perform. This resection is called type 1-2. And this is the project of the prosthesis that we wanted to use, with the fixation with 2 stems inside the sacrum. So one stem in S1, one stem in S2, and this is the X-ray of the reconstruction. Another application of custom-made implants are joint sparing prostheses. We have seen joint sparing resection treated and reconstructed with biologic solution, with allograft, with vascularized fibula, but also prosthesis can be used. But in this specific case, you need to go for a custom-made prosthesis. There are no prosthesis, modular prosthesis to replace this kind of defect. And another indication are lengthening prosthesis in pediatric patients, which are very, very useful. This is another revolutionary device because these are lengthening prosthesis which can be lengthened without operation in outpatient clinic with the aid of an electromagnetic field. So there is a progressive lengthening of the prosthesis without the need of a new operation. But these are custom-made implants, and you can decide how you want to produce the stem and how you want to achieve the fixation on the patient's bone. In this specific case, we used a curved stem, smooth at the tip, but hydroxyapatite coated at the base with anti-rotational spike. And these are lengthening prostheses that have a maximum lengthening potential. When you reach the maximum lengthening potential, you have to replace the prosthesis, like in this case, but maintaining the stem in situ, which is very, very important. So you replace only the prosthetic body. Another important possibility that we have now is to be able to correct specific deformity at the end of skeletal growth after bone tumor reconstruction using new devices. We have seen that lengthening nails can be used to correct deformities, but there is another interesting device, which is the hexapodal external fixator, which allows us to correct multiplanar deformity, when we have deformity on more than one plane of the space. And this technology comes from the middle of the 20th century when was introduced this Stewart platform in 1965 with these several degrees of freedom motion. So with this device, you are able to correct deformity on the sixth plane of the space. So shortening, lengthening, varus valgus, rotation, and recurvatum and procurvatum. This was a patient treated for a Ewing sarcoma of the fibula that at the end of skeletal growth presented a severe shortening and recurvatum. And thanks to these devices, the hexapodal fixator, we were able to correct completely the deformity with an excellent functional result of the patient at the end of skeletal growth. This is another patient with a recurvatum and shortening deformity after reconstruction of the distal tibia for an osteosarcoma. And also in this case, we use this device, the hexapodal fixator. You see the osteotomy under the tibial tuberosity and the progressive lengthening and correction. And this is the same patient that every day there is a software that gives you the planning of the correction and say to the patient which bolts have to be moved every day to correct the deformity progressively in all the planes of the space. So very, very interesting device. So in conclusion, we can say that surgical margin is the unique surgeon-related prognostic factor for the patient. So this is very important. We have always to remember this when we begin an operation. And surgical resection is a balance between safe surgical margins and functional preservation, so to preserve as much as possible healthy tissue and important anatomical structures. The advances in imaging technologies, preoperative adjuvant treatment, and also digital planning allow conservative procedures, as we have seen, joint sparing and multiplanar resections. But for this, we need intraoperative guides. We can use cutting guides, custom-made. We can use navigation system or intraoperative CT, or in the future, probably augmented reality will be of help. 3D printed custom-made technology for personalized surgical resection and reconstruction is essential, as we have seen, and we can use non-invasive new devices for specific multiplanar deformity correction. Thank you for your attention.
Thank you, Professor Campanacci. Despite the relevance of surgery in bone sarcomas, sometimes surgical resection may be highly morbid or impossible. Radiotherapy may be considered in patients with unresectable tumors or as adjuvant treatment of tumors at high risk of local recurrence. Radiotherapy, especially modern radiotherapy techniques, including heavy particles and intensity modulated radiotherapy, may offer important advantages and should be considered where appropriate. I invite now Professor Beate Timmermann, who will provide the radiation oncologist perspective. Please, Professor Timmermann, the floor is yours.
Thank you. I start my presentation. So, yeah, I would like to highlight some developments from 2021, and I thought I would go a little bit into challenges in general in radiating bone sarcomas, look into some needs and open questions I feel which are really relevant, and then highlighting what was done in 2021. So I guess most of you are aware that we can use radiotherapy in bone sarcomas, even if I think it is rather used in Ewing sarcomas and chordomas and chondrosarcomas, and just in the minority of cases in osteosarcomas. Typically, we see patients with tumors of the base of skull, spinal or paraspinal side, but also pelvic tumors or tumors of the sacrum. I think what is challenging is that we see adolescents and young adults, but some of our patients are really very young, even under age of 6 years. And what is also challenging that we typically have not only high local intensity in limited radiosensitive tumors, but also sometimes very intense multimodality treatment burden, which may impact on the risk of toxicity from radiotherapy. So that makes it, I think, particularly challenging that, of course, we have to give intensive treatments, but we need to, of course, have it feasible delivered to our patients. And we have lots of conflicts in radiotherapy when looking at bone tumors. I told you already that the tumors are not so radiosensitive, which means that we have to give rather high doses. So here you see the range of doses we typically give in bone tumors between 50 and up to even 74 gray. And these are really high doses when you look into the organs at risk we have to consider. So of course, depending on the site of the tumor where we have to treat, we have different organs at risk to be considered. So in the cranial area, we have the brainstem, the chiasm, we have the inner ears. In the spinal diseases, we have the spinal cord to be considered, the kidneys, lung, or intestine or bowel. And in pelvis, we have also intestine, but rectum, bladder, gonads. And here at the right side, I listed you some, let's say, rough dose limits, what those sites would tolerate. And you see, if you look at the numbers, you see here that this is typically lower than what we need to give. So the tumor dose we have to deliver exceeds the dose tolerance of very important organ at risks. And this means that we always go along a very thin line when doing the treatments, because we may exceed the tolerance of the normal tissue, which we should not affect in order to avoid relevant toxicity. And this, of course, means that we really need technologies of radiotherapy which helps us to spare normal tissue while giving high intensity, high doses to the tumor region. So even after administering already radiotherapy over 100 years in bone tumors, we still have to admit that we have lots of open questions to be addressed in bone tumors and radiotherapy. So, for example, we are still struggling with the question when we should give surgery only or radiotherapy only, or combination of surgery and radiotherapy. We also have to understand how can we do more risk adaptation of dose intensity in order to not overtreat any patient, but only giving the dose which is exactly needed by every patient in individual risk scenarios. How do we combine optimally our therapies, not only surgery and radiotherapy, but also with chemotherapy or immunotherapy? What is the best timing of radiotherapy? Should we give it before surgery? Should we give it after surgery, for example? I think these are really relevant questions which still are not answered for the majority of the bone tumors. What is the best radiotherapy volume to be treated? Here at the lower right side, you see an exercise of radiation oncologists who were asked to define the treatment volume of radiotherapy in a Ewing sarcoma of the pelvis. And you see the spread of these contours. So this is a cloud of, let's say, proposals, what should be irradiated. So obviously we don't have a common understanding of what the treatment volume of radiotherapy should be in bone tumors. And how can we assure that a good quality is performed? Do we need structures to help people to do optimal radiotherapy? And of course, also what is the best technology to be used when giving radiotherapy to bone tumors? Because we have several different ways to do it with particle therapy, protons or heavy ions. We have photon therapy, we have IMPT with image guides, we have brachytherapy, we have intraoperative RT. So we have to decide what kind of radiotherapy to give. And I guess this is only a part of the questions we have. And so this is just also to highlight some of the questions in terms of combinations. We sometimes have really challenging scenarios. So for example, this was a bone tumor in a very young child, and you see this huge extension of the primary tumor in the invading the central nervous system structures, the brain of this child. And this child had intensive chemotherapy. And it was really difficult to decide what intensiveness of radiotherapy would be tolerated in the central nervous system when having high-dose chemotherapy before, which also is an important burden for the central nervous system. So these are typical scenarios where we all have concerns if the intensity of multimodality treatment may exceed the tolerance of the normal tissue. So what do we need? Of course, we need to do retrospective analysis to see what did we achieve with the treatments we have already delivered. We need clinical studies to look prospectively into what to do best. The trials, of course, have to cover all modalities, which are important for bone tumors. We want to understand what is the a consequence for quality of life when we do treatments, what are the side effects when we do treatments, where do we have relapses, did we cover all areas at risk, or did we miss any important edge maybe of a tumor bed because we were too conservative when doing our treatment fields. And of course, we also need to cooperate because, as it was said already, we have very rare diseases. So we need to gather our experiences and data in order to have statistical relevant results from our analysis. So when I thought of, okay, what should we highlight from 2021, I thought I should go into what is published, what trials are ongoing or open or in a conception phase, and of course also what important cooperations we could form and establish in order to move forward. So when looking into publications, the publications were addressing several fields. So it was on overall management and what is the role of RT. People looked into how can we offer best treatment in low and medium income countries, which of course is a general concern, not to leave behind the countries and patients from countries with difficult financial situations and limited structures. What technologies were used. We had lots of publications on side effects and feasibility, but also on new systemic treatments and radiosensitizer, which may help radiotherapy to have an effect and response in bone tumors. And of course, also on a combination of radiotherapy with surgery, which is of course also a local treatment strategy. So just to give you some examples, we have seen important activities informing practice guidelines. So this is a practice guideline on bone tumors, and you see here, of course, in osteosarcoma, radiotherapy is primarily given in unresectable tumors, whereas in Ewing sarcomas, it plays a role nearly in all tumors, or at least in more tumors, I would say it's one of the modalities, either surgery or radiotherapy or both, but it plays a role, and we discuss it typically in nearly all patients, and it may be also considered for metastasis like in whole lung radiotherapy. This is one example also looking into palliative versus non-palliative treatment. And we really see that if we want to go for curative treatment, typically high doses are given here. It's a mean of 60 gray, but going up to 70 gray. In palliative treatment, where the focus is on not having toxicity, typically doses are much lower. But of course, also treatment results are inferior. So I think this is really important. And it also shows, if you see here two time periods, over time, the dose increased. So we have really understood that we need higher doses in bone tumors to see an effect. This is one example of looking into low and medium income countries. So here also from Egypt, we have some publication, and you see that also in low and medium income countries, radiotherapy is an important modality. Here in this Ewing sarcoma group, nearly 2/3 of the patient radiotherapy was delivered either alone or in combination with radiotherapy. And what they also showed, and this is also known to us, is that in very large tumors, here in tumors over 8 centimeters, we have an issue to achieve a local control. I told you that modern modalities are really important, and so this is one example from our facility on bone tumors of the pelvic and lumbar region. And in those proton centers, typically those patients really accumulate, because when higher doses are needed, proton beam therapy typically has advantages. So we here could publish experiences with 81 patients, and we luckily saw nice results with regard to local control here, with about 75% local control rates. However, as you see here, event-free survival was limited, so we lost patients due to metastasis. And of course, this is one issue, radiotherapy is only a local modality like surgery, so we do not affect the risk for a spread or dissemination. This has to be handled by chemotherapy, but unfortunately we have learned that Ewing sarcoma is not only a local issue, it's a systemic issue. So therefore systemic treatment are of high need regardless of local therapy. We also have one paper seen which is not only highlighting proton beam therapy, but also bringing up the question if preoperative radiotherapy is of advantage in Ewing sarcomas. And I think this is one of the discussions we are also having because we would like to give more preoperative radiotherapy, which was superior in this investigation. However, as we want to look into chemotherapy response, typically in Ewing sarcomas, we cannot give preoperative radiotherapy, which from a purely radiotherapy point of view is a pity. We would like to give more preoperative RT, but we do it quite rarely in Europe, or at least also in Germany. Here is a paper on quality of life. So of course, this is also of major importance now. We are not only looking into how to cure a patient, but also what the treatment burden after therapy is, or how we can avoid to have a high treatment burden. So therefore, here is an evaluation of particle therapy and quality of life and functional outcomes. This was quite a promising results for particle therapy. So I think really we try to learn how to deliver intensive doses, but still maintaining a good quality of life. Many people also really look into the understanding. So when do we have issues to preserve function? What is the risk in irrelevant side effects? And this is one paper on chordomas and chondrosarcomas of the base of skull. They require the highest doses in the bone tumors with doses exceeding 70 gray. You see here the median dose was 73.8 gray in this publication. So this is really very high dose. And I told you that typically we consider chiasm to tolerate 54 gray or so. Here they could see they could demonstrate that despite the very high doses they have administered next to the chiasm, still the incidence of vision loss was low with 2.1% at 5 years. They saw that 60 gray may be the dose limit rather than 54, which we historically have used, but that we have also looked into comorbidities of a patient to understand the risk of function issues. We have also tried to understand what kind of compromises can we do safely without risking an increased risk of local relapse. And we always have issues of forming our compromises because, as I said, the dose to the tumor would exceed the dose the organ at risk will tolerate. So we have to do compromises. And here, interestingly, they found that compromises to limit the dose to 60 gray or less, or 66 gray or less, was relevant in chordomas and chondrosarcomas. So we have to try to exceed this dose despite the organs at risk, which may be next to the target. There are also very practical papers here, for example, how can we decrease toxicity when doing pelvic radiotherapy with high doses, and this typically we see in bone tumors, but also in others like soft tissue sarcomas. But here we have typically higher doses in bone tumors, and they give very practical advice, like treating with a full bladder rather than with an empty bladder in order to elevate some bladder tissue out of the treatment field, covering symmetrically bone in order to avoid asymmetrical growth, avoiding growing hip joints, sparing gonads in boys. And so I think this is also very important to look into practical advice how to lower the risk for toxicity. We have also one paper looking at particle therapy and also introducing spacer. So here the sacrum had to be treated, and the people were afraid to have a high dose burden to the pelvic organs. So they put surgically spacer between the sacrum and the inner organs in order to protect them better from radiation therapy. And then, which is also, I think, interesting, is that people are now working on formulas how to sensitize tissue or tumor tissue to radiation. So here are two examples of potential drugs which could sensitize the tissue for radiation, which means with the same dose you may have a greater effect. And what you see here is that without sensitizer, more tumor cells survive. And here with the sensitizer, with the same dose, less tumor cells would survive radiation. And here you see the same with another radiosensitizer. And this is the same here, just shown in those graphs. So I think this is also interesting when looking into bone tumors. And we also have one project ongoing in our institution to test a combination of nanoparticles with proton beam therapy in order to increase efficacy of radiation therapy, or having a lower dose with the same effect maybe being better feasible for patients. So I think this is also an important path. We have also important studies ongoing on bone tumors. So this is one on sacral chordomas. This is an Italian study, but this is done in Europe, and we had very lively discussions with particle centers before how to do it, to allocate patients either to radiotherapy or to surgery. And I think this will be very interesting in a patient cohort where we also really have the question of how to do it, doing only surgery, doing only radiotherapy, doing combination. So here we are expecting very interesting results to understand the best local therapy for those highly challenging patients. Within the Ewing sarcoma group, we have two study concepts currently developed, and those studies will hopefully start soon. And interestingly, both study groups, the Euro-Ewing trial, but also the Inter-Ewing 1 trial, will look into the effect of dose escalation. So we have two dose levels in the Inter-Ewing 1 trial for definite and or post-operative, so RT only or surgery plus RT group. And we have similarly here two dose levels for different risk groups, either in post-operative radiotherapy or in radiotherapy alone. So obviously here we really want to understand better the dose level we need to apply for patients. In the newer protocols, we also want to have quality assurance programs to make sure that the field of radiotherapy is appropriate for all patients. So I think this is really important. And this is from the sacral trial, where we really also try to give very detailed information of how radiotherapy should be given examples and drawings of the fields to be delivered. In terms of corporations, we have, I think, very nice initiatives to come up with more international cooperation. So the EEC RT working group is really a great chance, having lots of radiotherapists from all sorts of countries together, discussing how to improve radiotherapy, how to perform research projects, how to gather data from different study groups. So I think this is really an important initiative. We may, for example, also really look into recurrence and distance from field border in order to understand better what kind of field we have to deliver. And I think what we should also not underestimate is that this kind of networking, international networking and cooperation, really helps us to discuss with each other really challenging cases. So this is just one example where I was contacted with a challenging case and question if I could give advice, and so we started an email communication. I think this is really important, that with those difficult patients, you are not left alone, but you have a group with which you can discuss cases and help to take a difficult decision. We also have huge cooperative activities, which I think are really helpful in future. So this is one example of an EU grant given to an initiative looking into dose effects of radiotherapy. This is primarily on children, but of course also sarcomas will be included in this cohort. So we want to gather data of about 2,500 children receiving RT and looking into some domains, how dose would affect on different domains like quality of life or cardiotoxicity or endocrinopathy, secondary primary cancer. So from forming those international consortia, we can gather lots of information, and I think this will help us to do better in future. So in summary, I hope you understand why I feel radiotherapy in bone sarcomas is really challenging. That I have to admit in a way that despite 100 years of experiences, we still have many open questions to be answered. Because it's so challenging, modern RT techniques are really important. It's also important that we have close interdisciplinary collaboration, because you can never cure Ewing sarcoma without chemotherapy. So local therapy typically is not enough. You need all modalities. We have important research projects ongoing. We have interesting new trial activities, and we have large cooperative initiatives. And I think all these activities will help to improve radiotherapy and also feasibility of treatment in future. Thank you.
Thank you, Professor Timmermann, and thank you to all our speakers for a very excellent update from very different perspectives. All of them are fundamental for a multidisciplinary approach. Many challenging topics have been addressed. So let's move on to our Q&A session. You can raise questions by raising your hand for direct questions, or send them through the chat. We have a question for Professor Campanacci from Caroline. Professor, do you have a preference for certain surgeries for specific age groups?
Of course, there are different indications in different age. I have seen from the question that the question is related to the indication to rotation plasty. Rotation plasty is a kind of operation which was very popular in the past. Now the indication are less, but is an operation which I think is still indicated in the very young child, especially below the age of 8. And another point is that rotation plasty is a definitive procedure, so just one surgical procedure lasting for the life. If you want to avoid it, you have in the young child, you have to begin a path, a journey with the patient, because you have to give a temporary solution, like using allograft with resurfacing prosthesis. But these are procedures that will require further surgeries during the growth of the patient. Every surgical procedure has a specific complication. And so this journey can lead to a success, but can lead also to a failure and to the loss of the limb. So this must be clear. So this is the difference. One operation, rotation plasty, one operation for the life, or we want to try to save the limb in the child, but this journey will be a long journey. So several operations during the growth. which hopefully eventually will be successful, but we don't know.
Okay, thank you, Professor Campanacci. A question for Dr. Gaspar. Dr. Gaspar, do you think there is an argument for using a combination of optimal selective tyrosine kinase inhibitors, for example, PDGFR, instead of using a multi-tyrosine kinase inhibitors?
That's a difficult question because, as I show you, for example, with the IGFR example, it did not work. But maybe there is another kinase that is most important, and PDGFR can be one of that kinase, especially in sarcoma, and maybe it will be more efficient than it was with the single one targeting IGFR. There are some trials ongoing with EGFR and FGFR inhibitors. Then maybe we will have some answer from that trials, but today I don't have the answer. We don't know which one is the best, the most important in that disease.
Okay, another question for Professor Campanacci. Do you collect quality of life data for the different procedures? If so, do you use a specific pro forma?
Well, we collect the data. We have some score system for the functional evaluation. We use more these systems than quality of life score system, but we like to collect them in our file. Of course, it is very important, and especially to see what happens with time, because this complex reconstruction may have an initial very good, excellent result, but with time they can have problems. So what we are beginning to look at now is long-term results. So long-term results and long-term failure of our reconstruction, because the limb salvage era, began about in the 80s of the previous century, and now we have 40 years, more than 40 years follow-up, and we want to see what happens at long term with this reconstruction, and especially the difference between biologic reconstruction and synthetic reconstruction. So the difference, if you use bone grafts, if you use the bone of the patient, if you use biological solution with synthetic, prosthetic, metallic solution. So this is very, very interesting to see, because we see that with biological solution, with time, the results will improve. So the result will be better. With the synthetic solution, with prosthetic solution, with time, the results will be worse. So there are very, very, very different situations.
Okay, thank you. We have a question from Caroline for Professor Timmermann. It's about the use of samarium. Are there possibilities for samarium as an agent for bone-forming tumors?
Yeah, so samarium is kind of an old story still. We have very little data. So primarily samarium is used for metastases and palliative scenarios because it is known to improve bone pain. So I think the majority is used for palliation to reduce bone pain. However, there are also, let's say, case reports on osteosarcomas, for example, where it was used in a refractory situation, so where we had not a lot to offer, let's say, where there was a good response seen on samarium. And we have also treated, let's say, individual cases after samarium was given. So for example, we have some cases where in young children, people wanted to delay radiotherapy and therefore gave samarium and achieved some stabilization of disease, and radiotherapy was postponed. So I think I would not call it a standard therapy in curative scenarios. It's rather used in palliative scenarios. However, in individual cases, it was used successfully.
Okay, thank you. A question for Dr. Gaspar. What is the influence of age on treatment of osteosarcomas, taking into consideration the two incidence peaks?
Sorry, can you repeat the question?
What is the influence of age on treatment of osteosarcoma, taking into consideration the two incidence peaks?
There is a huge impact because the tolerance of the drug are completely different between age. Then usually in the youngest patient, we use a regimen that are based on methotrexate. And depending on the country where you live, you will receive cisplatin and adriamycin. But for example, in France, we try to don't give it to the youngest children, at least young adults too, up to 25, try to avoid cisplatinum and adriamycin to avoid late effects of these drugs. The cardiac toxicity of anthracycline and the ototoxicity of cisplatinum. But adult patients, especially the oldest one, cannot tolerate methotrexate. Then most of the adult population does not receive methotrexate. They receive cisplatinum and adriamycin, ifosfamide also. And there is also an adaptation to the oldest one that cannot tolerate either all these drugs because this remains regimen that are quite toxic in terms of hematologically. Then there is adaptation also for the oldest patient, and there is a specific trial that is called, I don't know if it's a trial still open, but what's called Eurobos, that was specific for the old population with the second peak of incidence. And probably it's not the same disease.
Okay, thank you. A question from Shannon for Professor Timmermann. Some skull-based surgeons in the US and in Europe are looking at the pathology of skull-based chordomas to determine if radiation can be withheld for some patients. What do you think about this approach? What are you hearing from your colleagues in radiation oncology?
Yeah, no, I think this is one of the, let's say, open questions. So we typically recommend post-operative radiotherapy for all chordomas, despite histology. I think we do not fully know, but we have seen a lot of recurrences in patients not receiving post-operative radiotherapy. And still, this is more kind of gut feeling than evidence-based. So we have to admit that we don't have a lot of good data. But I think we had recently we published a review, and I was trying to review all data. And I still think I would recommend it in all patients, regardless of surgical results and also regardless of histology. We have some, let's say, difficulties with pediatric dedifferentiated chordomas, where we have a high rate of metastases, which is very rare in the adult forms of chordomas. So there we have to discuss, for example, chemotherapy. So that is at least some different approach according to histology and age. But I think so far we would not adapt local therapy to histology.
Okay, thank you. I have a question for all the speakers. International collaborations are crucial in building evidence and improving treatments. In your experience, which are the main obstacles of such collaborations? And what can we do to overcome barriers? Dr. Gaspar.
Can I do a non-political correct answer?
No.
I think the main barrier are egos. But to be more serious, there are several barriers. One is the different culture that we have between pediatric and medical oncologists, or not just oncologists, but surgeon. We have different culture. As surgeon, radiotherapists, we try to avoid late effects for a long time in children, and then we have developed different ways of thinking than medical oncologists do. There is not best way or a wrong way, but trying to bring people thinking and discussing together might be difficult. And I think the second difficulty are regulation. There might be different between countries, and they might bring difficulties that are not expected, that can annoy a lot of people and make things very difficult. Then if we can try, at least in Europe, to have a regulation that is the same everywhere and not different because you're changing of country, that will be great. And the last thing is being, how can I say? Sorry, I don't know the English word, but not be selfish and give the opportunity to patients to travel when they can travel for something that is not available in their own countries.
Okay, thank you. Any other questions from the audience? Wow, I'd like to warmly thank our speakers for their time. I believe that
Ornella, sorry to interrupt, but I saw Carolyn raising a hand.
Oh, sorry.
Sorry.
I'm sorry. I haven't seen.
For Professor Timmermann, we've seen in the chordoma population that the bigger centers in the US, and that's a partner in Pittsburgh, but also in the Leiden University clinics, they tend to save the radiation for the lival chordomas. So it's not the histology they're looking for, but it's the location of the tumor. And well, Dr. Partner has done most clival surgeries on chordoma, I guess, in the world. So he's kind of an expert in the field. But also in the Leiden neurosurgical department, they tend to hold off the radiation until, well, either there's growth or other difficulties.
Yeah, thank you for this comment. I think this is, but I still don't know if this is evidence-based.
No.
We have the same, of course, and I think that is also what I would want to add to the question, also on what are the hurdles, let's say, for cooperation. I also think that with regard to radiotherapy, the problem is that we only see a patient if we are, let's say, informed about the patient. And in chordomas, or like you're saying, we don't see a lot of patients because the surgeons send the patients home after surgery and saying, like, now the treatment is complete, and we will never see the patient. So I think one really important point for cooperation is the interdisciplinary tumor board as the start of any interdisciplinary cooperation, to understand reasons or philosophies of the other disciplines. And sometimes I'm frustrated that the surgeon, sorry, Professor Campanacci, I hope you don't mind if I say it, but there are some surgeons who do not involve the other disciplines. This may be the radiation oncologist, it may be also the oncologist for some diagnosis. So I think we are still not at the point where all patients with malignant diseases or benign tumors are discussed in the multidisciplinary board. And I think this would be really important to have the full understanding and to discuss very open on what could be done and what could be offered. And sometimes we have to ask the patient if he wants to have more certainty and maybe then additional radiotherapy, or if he wants to accept a higher local failure rate, but having the chance not getting radiotherapy. So I think this needs to be discussed with the patients as long as we don't have evidence. And Professor Campanacci, I believe that you are working, of course, in this interdisciplinary rounds, but many surgeons don't, or feel they can decide if a patient is presented. So I don't know, Caroline, what the situation is in your experience, but we have some, sorry?
No, I think that Germany has a problem, if I might say it, if I would say it like that. The specialization for both sarcomas not as well as you might hope. You have been working for 6 years now.
We cannot hear you properly.
Oh, I'm sorry. Better like this? Yeah. Better or not? No?
No.
I don't know. Do you hear me now?
Yes, I can hear you. Yes.
Okay.
Okay.
I'm trying to get some kind of operation. No? It's my computer. I don't know what's happening.
Okay. Okay. If there are any questions, I'd like to warmly thank our speakers for staying with us. I believe it's important to underline that the research to improve treatments never stops, even if many challenges are still to be faced. And this is the reason why it's crucial to build a stronger bone sarcoma community, increasing the interactions between experts and patient advocates in a systematic manner, developing close collaborations, because together we can make the difference. Thank you, everyone, for joining us.